All right, welcome everyone. Thanks for joining us. At the bottom of your screen, you'll see several widgets for your use during the presentation. For example, if you have a question, please click the purple Q&A icon to the left. You will be able to download your Sherman HRCI credits at the conclusion of the webinar by clicking the yellow certification widget. And now it's Compliance Update with today's hosts, Dan Cooperstein and Dot Summers.
Hi, and welcome to Compliance Update. I'm Dan Cooperstein.
And I'm Dot Summers.
And Dot and I are happy to be here with you today, presenting live from scenic Camden, New Jersey, in front of a real studio audience. And if you're new to our program, this show is about presenting you with the really important health and welfare benefits compliance news, and of course, discussing the impact of these developments on your benefit plans without getting political, of course, because, well, that's just not what the show is about. And just as some background on me and Dot, Dot and I work together at Corporate Synergies, overseeing the national benefits consulting practice, helping clients out in all aspects of employee benefits compliance and regulatory matters. Dot brings over 20 years of experience in benefits to our team and is our subject matter expert in all things health and welfare. I bring almost 15 years of experience practicing as a lawyer in employee benefits and executive compensation matters, including experience assisting clients of all shapes and sizes with DOL, IRS, and other government audits and investigations of their benefit plans.
So Dan, with all that experience, this is about the time that I would say, hey, you must be an ERISA geek, you must be an ERISA nerd. We've been doing this a long time together. This is our 4th show. I think it's time for a promotion. So today, you're going to be an ERISA ninja.
ERISA ninja. Wow, I like that. That's a good one. That's quite a promotion. Thank you. I guess that's one way to put it. Yeah, certainly beats the heck out of ERISA nerd. So today, we are going to be presenting about wellness plans and how they were impacted by the famous rule reversal decision in AARP versus EEOC. And in that case, decided all the way back in 2017, a federal district court in D.C. vacated, or in other words, invalidated, the incentive portions of the EEOC's employer-sponsored wellness plan regulations, which were initially promulgated under the ADA and GINA back in May of 2016. And these incentive rules were then formally removed by the EEOC in December of last year, with an effective date for their removal of January 1st of 2019. So while we're going to discuss the details of the AARP decision and its impact in a slide later in today's presentation, the most important thing to understand about this, mostly procedural case, is that as a result of it, employers have been without incentive rules under the ADA and GINA for all of 2019. And we've all been essentially operating in a legal vacuum or gray area where it's not entirely certain how much of an incentive or surcharge an employer can apply to its wellness plans that are covered by these 2 laws. So as a result, we're going to spend quite a bit of time today getting to understand which rules are still in place and which have been vacated. And we'll also talk about the practical steps that your wellness plan can take to ensure compliance and reduce exposure to litigation and government fines and penalties.
But first, as we do in every webinar, we will discuss some of the most important developments in recent months impacting your health and welfare plans and insurance in our Compliance Updates segment. Dan, why don't you get us started?
Sure. So let's start with some of the big news around health reimbursement arrangements, or HRAs. And this is really the biggest development that's happened in not just recent months, but in many years. And it's something that we've talked about in earlier shows. On June 13th, the Department of Health and Human Services, the Department of Labor, Department of Treasury, and IRS, which we'll just refer to collectively as the agencies, issued a set of final regulations designed to expand employers' ability to offer HRAs to their employees, and it allowed them to be used in new ways that would really have been inconceivable just a couple of years ago. The rules introduced 2 new types of HRAs, the first being the Individual Coverage HRA, or ICHRA, which is an HRA that can be used by an employer of any size to reimburse individual coverage, whether that's purchased on the individual market or on the exchanges, so long as it's integrated with that individual coverage and certain other notice and substantiation requirements are met, so among other requirements. And the other new type, which is called the Accepted Benefit HRA, or EBRA, is the other new type. The EBRA allows employees to pay for certain HIPAA-accepted benefits and does not need to be integrated with an employer-sponsored traditional medical plan, So in other words, employees can enroll in the EBRA without enrolling in an employer-sponsored traditional medical plan, as long as the employer offers a traditional medical plan along with the EBRA. So really big developments. Prior to this regulation being issued, outside of standalone retiree HRAs, in the agency's view, only integrated HRAs, that is, HRAs paired with employer-sponsored group health coverage, could pass muster under the ACA. The ICHRA is quite game-changing in that it allows employers to take all of their workers, or just a class of their workers, and essentially say to them they can now go and get their traditional medical plan on the exchanges or in the individual market, that is, without having to offer them a major medical plan that meets the ACA's minimum standards, and also, most significantly, without any ramifications, that is, without having to pay an ACA employer mandate penalty, assuming, of course, that the ICHRA is funded at a certain level to make it be deemed affordable. And while final regulations have yet to be issued on what will be considered affordable for purposes of an employer's funding of the ICHRA, the agencies have explained a possible approach that will be used as a baseline by the agencies for regulations that are going to be issued in coming months, and specifically that approach, which was outlined in guidance issued late last year, explains that employers can assume that the amount that the employee is paying for individual coverage is the same as the premium amount for the lowest cost silver plan for self-only coverage available through the ACA exchange in the rating area in which the employee resides. Then, of course, when you take that amount and subtract from it the amount that the employer is offering or funding through its ICHRA, you should be able to determine whether the individual coverage, when taking into account the ICHRA's funding from the employer, will be affordable to the employee under the currently existing applicable affordability safe harbors. Now, while the IRS is still working to finalize these rules, it's important to note that these final regulations go into effect for plan years beginning on or after January 1st of 2020, which is really right around the corner.
So, Dan, basically, even though the IRS hasn't explained precisely how the new ICHRAs are going to be affordable for employers yet, they still haven't extended the time frame or deadline by which employers must figure out this compliance.
Exactly, and I think that's really one of the strange things here. I mean, while it's likely that they'll use a system outlined in their guidance that uses the same 3 affordability safe harbors that employers can use now, the actual specifics of all of it are still to be determined. And just to summarize on this final regulation, while we would definitely recommend that you discuss the potential cost savings applicable to your organization of utilizing these 2 new HRA types, there are also downsides to implementing this, especially if your organization is going to try to do it in the 2020 plan year. I mean, I see 2 main downsides here, really. The first risk is that we don't have final regulations, obviously, on what will pass the threshold for affordability when it comes to the ACA's employer mandate penalties, and that means that many plans, especially calendar year plans, are going to be getting final rules probably right before, if not during, open enrollment, and that's just way too late to design a contribution structure for this, at least for most large employers out there. And the second big issue that I see is about employee hiring and retention. If your organization is in a competitive market, and certainly the economy is still quite strong despite the current trade fears, you're going to need to compete for the best talent out there, and getting rid of a major medical plan and substituting it with an ICHRA isn't exactly going to make your organization stand out among competitors as having a rich benefits program. So in another significant development that's really spawned several other developments, on June 24th, the President released an executive order designed to improve price and quality transparency in healthcare. Among other things, the order called for the agencies to issue guidance and regulations that would allow high-deductible health plans to remain compatible with HSAs while covering medical care that helps individuals with chronic conditions and before the deductible, to propose rules that would allow plans to treat these expenses related to certain arrangements, potentially including direct primary care arrangements and healthcare sharing ministries, all these things as eligible medical expenses under Code Section 213D, and also to increase the amount that can be carried over after the year end under health FSAs. So a lot of different proposals there. And with respect to transparency, this new executive order requests the agencies to issue rules that require insurance carriers, sponsors of self-insured plans, and medical providers to make available information about expected out-of-pocket costs to patients before they receive care. And it also requests HHS to increase access to de-identified claims data from group health plans for researchers, innovators, and others in a manner that ensures patient privacy and security.
So basically, President Trump is saying agencies make health plans cost less and make the cost and claims data more transparent.
Yeah, exactly. It's both in some ways, show me the money, and also, let's work together to, reduce the costs of health plans. Okay, and one of the things that really is, as an offshoot of that development that kind of came out of that, the IRS responded by issuing guidance on July 17th that expands the list of preventive services benefits that can be offered under a high-deductible health plan without being applied to the deductible and without any adverse effect on HSA eligibility. Under the prior HSA rules, the definition of preventive care generally did not include services or benefits intended to treat existing illnesses, injuries, or conditions. But now, as a response to this June 2019 executive order that we just talked about, the IRS implemented these new rules to change that. And specifically under the new guidance that the IRS released, which actually became effective on the day it was released, which was July 17th, specified treatment services and devices that are used for certain chronic conditions like diabetes and heart conditions are now considered preventive care for HSA purposes when prescribed for individuals diagnosed with the associated condition to prevent exacerbation of the condition or the development of a secondary condition. So, this is a pretty big development. Those services and items, along with the conditions for which they must be prescribed to qualify as preventive care, are listed in an appendix to the new guidance, and the list includes 14 medical services or items for individuals with 11 specified chronic conditions. And the guidance also explains the criteria that the IRS used to determine the list of services and items, but it cautions that services and items not on the list cannot be treated as preventive even if they meet the same criteria. Also, the IRS cautions that this list of preventive care services is not the same as the preventive services under the ACA rules. And then finally, another thing in the guidance is that services or items that treat complications or secondary conditions that occur, notwithstanding the preventive care, that is, in plain English, sort of other unrelated conditions that arise, right, are also not treated as preventive care under these new HSA rules. And so the IRS intended this to be a very, very specific list.
One thing that you said kind of quickly, but I think that it's a really important thing to understand about these new rules, that these are not the ACA preventative services. Things like have to be paid for with a $0 copay, things like well baby visits, pap smears, colonoscopies, mammograms, things like that. That isn't what this is about. These are simply about high deductible plans and the types of benefits that, if the plan offers them, cannot be applied to the high deductible's annual minimum deductible. Because under the HSA rules, you cannot have any other first dollar coverage for medical care. And in this situation, when you have these chronic diseases, some individuals, are putting a lot of money out of pocket because they are going towards meeting that high deductible. So I think this list is a really good, useful, and helpful to those individuals with chronic diseases.
Definitely, I think that's a really important clarification that you just made. That this really just only applies to the high deductible health plans annual minimum deductible. That's something I think is still confusing a lot of folks out there. They're kind of confusing the term preventive care with the ACA's definition of preventive care. So that's really a great clarification. Thanks, Dot. And so let's talk about some state mandates that are going on. And obviously this is another something we talked about on our last show. So I'm going to try to go through this pretty quickly. Obviously, as you can see from this slide, a lot has happened in the last couple of months. California and Rhode Island passed their own individual mandates, becoming the 5th and 6th states to pass these. These are the healthcare individual mandates that require individuals that reside in those states to get health insurance coverage or else pay a fine. Now it's becoming something of a trend as states are trying to preserve the quality of the risk pool in their exchanges after tax reform eliminated the federal, the ACA's individual mandate tax penalty effective on January 1st, 2019. So, the other states that have implemented the individual mandate laws are New Jersey, Massachusetts, Vermont, and D.C. And just in case you're wondering why we have this colorful map here on the left of the slide, anyone out there know what this is? Anyone? No? Bueller? Well, this is actually an electoral college map from the 2016 election. And as you can see, every one of the 6 states that has established an individual mandate was also a state that voted blue, that is, voted Democrat. in the 2016 election. And given that the voters in these states would likely have voted to keep the ACA's individual mandate, these blue states on this map are the places where the trend of states passing individual mandates is likely to continue. So we're going to keep watching those closely and posting updates about this trend on the ACA Now website. Additionally, one of the very interesting developments that occurred recently was that last month, New Jersey issued guidance explaining how their information reporting program is going to work under their state's individual mandate. And really, to summarize it very quickly, it's really essentially a lot like the ACA's information reporting program.
Exactly, and I think one thing that is clarified in the guidance that a lot of employers are still confused about is that this mandates reporting requirement applies to employers that sponsor health plans with participants that are residents in New Jersey. In other words, there are probably a lot of employers in Philadelphia, Wilmington, New York City that don't think this applies to them because they're doing business not in the state of New Jersey, or they're not sited in the state of New Jersey, but when it does, and now they'll have to file their 1094 and 1095Cs with the state of New Jersey in addition to the federal government. So these employers in Philadelphia, Wilmington, and New York City who have employees who reside in New Jersey, this mandate will apply to them.
Yeah, and that's right, and that's a big thing to remember, because the New Jersey individual mandate statute, right? It only refers to residents, right? Residents are the ones that it covers. But of course, if you have to you have to do ACA information reporting to show that the resident had health insurance coverage. So even if you're an employer out of state, that's something you have to do. And another interesting thing is that the statute itself incorporates by reference the entire regulations that the federal government used to enforce their individual mandate under the ACA. So we could be seeing, penalty letters going out to these employers, from the state of New Jersey that look just like the federal ones, if these employers don't comply with their information reporting requirements. So definitely something to check out if you employ New Jersey residents. And you can check out our e-alert or our ACA Now webpage to learn more about these reporting requirements.
And one other important item is that these forms, unlike the federal mandate, have to be electronically filed to the state of New Jersey, where under the federal mandate, employers under 250 returns could submit those forms via paper to the federal government. So that's a little bit of a change that even, if you were used to submitting paper, employers of all sizes will have to submit electronically to the state of New Jersey, and they do have a system for that. It's using basically the same technology as an employer would be to submit a W-2. There's some testing requirements. That's all, again, as Dan said, that's all included on our e-alert that we provided.
Great. Thanks, Dot. I'm just going to go quickly through some of the big court and legislative developments that have happened in the last couple of months. One of the big things that happened was last month, on July 10th, the Fifth Circuit Court of Appeals heard oral arguments in the case about the constitutionality of the ACA. That case, Texas v. AARP, is a suit that was brought by 18 state attorneys in general and the Trump administration, and it's really the latest legal challenge to the ACA, essentially saying that since the individual mandate is no longer a part of it, it's no longer constitutional. And so that decision was by Texas District Court Judge Reed O'Connor, who determined that it was unconstitutional at that level. This could go all the way, if it, depending on how the First Circuit decides on it, could go all the way to the Supreme Court, and obviously very interesting to see what's going to happen. We're watching that very closely. And then also the Third Circuit Court of Appeals joined other courts in ruling against the ACA contraceptive coverage regulation. So another very interesting development also happened last month. And basically the court upheld the preliminary nationwide injunction against these two relatively recent regulations that were designed to dramatically expand the exemptions to the ACA's contraceptive mandate based on religious or moral objections to that mandate. And the court held that neither the ACA nor the Religious Freedom Restoration Act authorize or require these final rules, and the court said because they lack a statutory basis, they're arbitrary, capricious, and ultimately unlawful. So as a result of this court decision, a nationwide injunction prohibiting the two regulations from going into effect remains in effect. And as a result, this really blocks the Trump administration from enforcing these rules and prevents those who object to contraceptives, whether on moral or religious reasons, from relying on the same rule as an exemption. So after this decision, there are now kind of dueling nationwide injunctions. There's another one in Texas that says that the government can't enforce the contraceptive mandate. So there's kind of a dueling injunctions that really raise questions over kind of the current scope of the ACA's contraceptive mandate. And this is another one like the other one that could, like the Texas v. Azar decision in the Fifth Circuit, that also could go to the Supreme Court before we get final resolution. And then finally, there was another case, Questle v. Yale University, which was AARP filed this class action lawsuit on behalf of employees of Yale University, alleging that the wellness plan violates the ADA and GINA, and we're going to be talking about that later after we talk about the AARP decision. And then let's talk just really briefly kind of what's happening in the legislation pipeline, kind of talk about how the sausage is being made in Washington and kind of what's coming down the pipe. And really one of the big things that we were watching really closely that we kind of expected to happen, but it really kind of did happen, was that the House of Representatives repealed the ACA's Cadillac tax in a 419-6 vote, so something definitely had a lot of bipartisan support. Obviously, it still has to go to the Senate and be approved by the President before the ACA's Cadillac tax is completely removed, but something we're watching very closely. There was also an update on surprise medical bill legislation, which is we had talked about in earlier shows, the No Surprises Act, which was supposed to kind of help with surprise medical bills, and surprise, surprise, the No Surprises Act was kicked down the road and moved, till after the summer recess. It was sort of delayed, which we kind of expected. And then as far as prescription drug reform, there's been a lot of discussion out there about prescription drugs as well as Medicare for all, and we've seen a lot of different proposals out there. And this is just a topic that just keeps on coming up in the news quite a lot, given that it comes up in the debates. But while there's lots of the different things being proposed, there's actually very little that's actually changing in this area. But that being said, one of the more exciting developments that we've been watching very closely pertains to drug importation as a method of reducing prescription drug costs. And on July 31st, HHS, along with the U.S. FDA, released a roadmap for a new proposed regulation in this area. Their proposal is called a Safe Importation Action Plan, and it outlines two potential pathways that would lay the foundation for the safe importation of certain drugs originally intended for foreign markets. I think a lot of that's going to come from Canada. It's a very exciting development because it appears to be a really practical way to lower prescription drug costs and have a really big impact on employers sponsoring plans out there. But of course, still very much in the works. But you can read about this new action plan on our ACA Now webpage. And finally, this is not so much a legislative update, but we thought we'd put it here on the slide. There is a regulatory update to something we talked about in the last show, which is that in our last show we discussed that that HHS had issued a regulation that would be on a going forward basis changing the indexing methodology for employee benefit plan limits beginning in the 2020 calendar year. Since we talked about it a lot in a lot of detail in the last show, we're not going to kind of go into all those details today. But essentially, the new indexing methodology, when it uses healthcare inflation as sort of the metric for increasing the percentages, it takes into account now increases in premium cost in the individual market, which is a new factor that had not been taken into account before, and which in turn is expected to have the effect of increasing the indexing percentages and plan limits by greater amounts each year on a year-over-year basis. We saw that actually this happen, the first time it was used was quite recently when the IRS made adjustments to their affordability percentages for the 2020 plan year and utilized the new indexing methodology. But this year, actually, the affordability percentage actually went down for the employer mandates affordability percentage from 9.78% for to 9.78% for 2020, which is down from 2019's affordability percentage of 9.86%.
When do you hear that? A decrease in relationship to any government ruling.
Yeah, it's very unusual, very strange. So that was unusual, but it probably is not going to happen in future years. All right, so let's talk about our featured topic today, wellness plans.
Woo-hoo.
Yes, and about how to get your wellness plan into shape from a compliance perspective. So, Doc, I can't tell you how excited I am for today's topic. I worked out all morning, prepared my whole body and mind for several hours before today's show, including mantra meditation, hot yoga. I even listened to a podcast of Oprah's Super Soul Sunday with Marianne Williamson, all that had to open my heart full of love. And so I'm like just super psyched for today's show.
Really, Dan? I think we really need to be honest with the audience here. I'm pretty sure you walk like 30 seconds from your cart in the parking lot into the elevator and into our office, right?
Okay, you're right. I was kidding. But I am still super, super excited for today. And I'm jazz hands excited. I'm talking with my hands here for today's discussion. It was like a good 2.5 minutes walking, so I did break a little bit of a sweat.
No, you didn't.
Okay, fine. Okay. Well, maybe you wouldn't call it breaking a sweat, but, you know, it was pretty hot out there. Anyway, so before we get started and talking about the AARP decision, since that decision primarily deals with changes to laws and regulations dealing with wellness incentives, we thought we'd do a brief, but maybe not so brief actually, overview of how the wellness plan rules work, with a special focus on incentives, since that's really what's really changing here. So to get started, we thought we'd do just some big picture stuff to give everyone the view from 1,000 feet up on how wellness plans are regulated, and a brief history of the regulation of wellness plans, which all began with this fat jiggling machine that you see here on the left of this slide. No, I'm actually just kidding. I'm pretty sure that's we're not going to go that far back.
Dan, I'm pretty sure that's how my parents, maybe even grandparents, used to work out.
Yeah.
Man, if it was only that easy.
Exactly, right? Definitely. No, we're not going to go that far back. So we're going to go to really about 6 or 7 years ago. And we have these two timeline slides here, which we're not going to go into detail on. It's really just more for your own reference. But really, even though wellness plans and related types of disease management and on-site medical plans have been regulated in some way or another for the last 50 years or so, as you can see from this timeline, it's really been the last 6 or 7 years or so where it's really just been a regulatory whirlwind. Just a ton of rulemaking and agency guidance. And, of course, we're not going to get to every single rule that's out there today, but we're going to give you a good idea of the major things that you should be taking into account and concerned about. And so, one of the things, as you can see from this big wheel of laws that are out there that are implicated by wellness plans, there's just a lot of laws that can be implicated when your organization uses a wellness plan. But the good news is that the application of a lot of these laws will really depend on what you're doing with your wellness plan, and not all of these will apply to most wellness plans. And in light of that, we're going to discuss today what we call the big three, which are the laws that have the most application to almost all wellness plans out there and put the most limitations on wellness incentives. And these are the ones that are, as you can see from the slide, that are in red, which are HIPAA, as amended by the ACA, as well as the ADA and GINA. The ADA standing for the Americans with Disabilities Act, and GINA, the Genetic Information Non-Discrimination Act. Those are two that we don't talk about as much, but they are important laws. So, Dot, do you want to get us started and give us an overview of how the HIPAA rules work?
Sure. And for this refresher, we're going to talk about how all three laws worked prior to the AARP decision, and then we'll talk about how that decision changed things. But with that being said, these rules the HIPAA rules, well, let's start with the ACA and HIPAA. These rules did not change at all as a result of the AARP decision, and technically they're still fully in effect in the way that I'm going to describe them. So one of the first questions that you really should ask is, when does HIPAA, non-discrimination, privacy, things like that, apply to my organization's wellness plan in the first place? So HIPAA applies to all wellness plans that are considered to be, quote, group health plans, unquote, regardless of whether your wellness plan is standalone wellness plan offered to all of employees on its own, or whether your wellness plan is linked or integrated with a medical plan. The first thing to understand is, what does the term group health plan actually mean? It means that the plan provides medical care, which is defined as amounts paid for the diagnosis, cure, mitigation, treatment, or prevention of disease, or amounts paid for the purpose of affecting any structure or function of the body. Additionally, it is defined as amounts paid for insurance covering medical care. So for example, examples of medical care in a wellness plan terms include biometric screenings, including cholesterol screenings, glucose screenings, physical examinations, flu shots, and other programs that are diagnostic or preventive. So in light of that broad definition, almost all traditional wellness plans will be considered to be group health plans and therefore must comply with HIPAA. Which plans would not be subject to HIPAA? Those wellness plans that simply promote a healthy lifestyle but do not provide any type of medical care. For example, maybe an employer's wellness plan is reimbursing a part of a gym membership, or a program that gives people basically just educational information about eating a healthy lifestyle diet. You know, they send out monthly newsletters to their employees, advising them on the different health factors and ways to prevent diseases. And so a wellness plan that it is itself a group health plan or part of a group health plan must comply with non-discrimination requirements under HIPAA. And the ACA updated those HIPAA non-discrimination requirements for wellness programs, and federal agencies issued final regulations on these back in 2013, which is really why, as Dan said, we call these basically the HIPAA/ACA rules. So as general knowledge, HIPAA generally prohibits a group health plan from discriminating among similarly situated individuals based on their health status with respect to eligibility, benefits, or contributions. Like, for example, group health plans cannot charge individuals different premiums based on a health factor, meaning your employees who are pregnant and have that health condition cannot be charged a different amount. They can't be provided a different benefit. However, HIPAA does create an exception to these non-discrimination provisions for certain HIPAA-compliant wellness programs. And to qualify this exception, a wellness plan must comply with the HIPAA-ACA regulations, which includes two categories of wellness programs. One, a program called a participation only, and two, a health contingent program. So let's quickly review each of these programs. First, participation only program. This is a program that does not condition eligibility for a reward on the participant's ability to meet a particular health standard. So examples of participation-only programs include completion of a health risk assessment, health education sessions, and participation in a biometric screening without requiring that any particular biometric targets need to be attained. For a participation-only program to comply with the regulations, participations in the program must be made available to all similarly situated individuals regardless of a health factor. Secondly, I mentioned health contingent wellness programs. Unlike the participation-only programs, a health contingent program is a program that conditions eligibility for a reward on the individual's ability to meet a standard related to a health factor. And such health contingent wellness programs must generally comply with 5 HIPAA conditions to be compliant. And I'm going to discuss those 5 conditions on the next slide. And of course, to confuse us even more, there are also 2 types of health contingent programs under the HIPAA wellness program. 1, an activity-only program, and 2, an outcome-based program. An activity-only program is a program that requires an individual to perform or complete an activity related to a health factor to obtain a reward, but does not require the attainment or maintenance of a specific condition. Examples of activity-only programs include walking, diet, and exercise programs, but it puts no requirement that, due to the walking, you've lost 10 pounds or you've dropped your BMI. It's just complete the activity and you can be eligible for the reward. And then by contrast, an outcome-based program is one that requires an individual to attain or maintain a specific health outcome, such as attaining a specific body mass index or cholesterol level. Okay, so let's talk about those 5 requirements. So for either an activity-only or an outcome-based health contingent program to comply with the HIPAA Wellness Program regulations, it must satisfy the 5 requirements outlined on this slide. First, participants must have an opportunity to earn a reward at least once per year. 2, the program must be reasonably designed to promote health or prevent disease. 3, there must be reasonable alternatives and waivers to the form. So For an example, if it is unusually difficult or medically not advised that a participant be able to participate in the wellness initiative, the plan sponsor must provide a reasonable alternative. For example, lots of employers have smoking cessation, or the wellness initiative is to be tobacco-free. Well, certain individuals may have medical condition because it is considered an addiction. It is it's an actual disease, and their doctor may say, this person, it's unusually difficult for this person who is addicted to nicotine to quit. So in that situation, the participant can ask for a reasonable alternative. The employer would then have to come up with some alternative way that the employee could meet the incentive. Maybe they attend, smoking cessation programs. They attend counseling, and so those are, a reasonable alternative to the wellness initiative. And it's also important that that reasonable alternative must be listed in plan documents, in SPDs, in enrollment informations. Really, basically, they're saying any time that you're communicating with your employees about the wellness plan, you must include that information. Now, the specifics do not need to be included. It's just a statement that an alternative is made available and to contact the plan participant.
The plan sponsor.
The plan sponsor. The number 4 condition is that the reward must be available to all similarly situated employees. And finally, 5, combined rewards for all programs under the same plan cannot exceed 30% of full cost of the group health plan coverage, with a maximum of 50% for tobacco cessation. So this is probably the most significant condition among the 5. And this is going to be tested, as you're going to see when Dan talks about how the AARP decision kind of overruled. So basically, the sum of the rewards for all health contingent wellness plan programs with respect to a plan can be no more than 30% of the total cost, with an additional 20% for a smoking prevention or to reduce tobacco use. Okay. So let's talk about this number 5, this incentives, as far as the rewards. As we said before, that the opportunity to obtain the incentive must be offered at least once per year. And when you're looking at the reward, how do you calculate that 30% or that 50%? So the combined rewards, as I said, for all programs under the same plan do not exceed 30% of the full cost of the group health plan coverage. So when we look at full cost, we're talking about the aggregate. That's the employer plus the employee's portion. If you have an employee-only plan where only the employees can participate, then that 30% is calculated off the cost of the employee-only coverage. Or if you are offering these programs or spouses and dependents are allowed to participate in the plan, then that 30% is based off the single plus one, single plus children, or family contribution amount. And then, as I also said, that there is an additional 20% to prevent or reduce tobacco use. So those same calculations can be up to 50%. But one thing to note, though, you could not have a 30% non-tobacco and a 50% tobacco. You cannot exceed 50% for both of those. Okay. All right, so let's talk about, the key takeaways from HIPAA ACA rules. There are fewer requirements for participatory programs. Rewards are either not provided or provided without any conditions. Rewards must be available to all similarly situated employees regardless of a health status. Non-health contingent, not health contingent, so rewards don't count towards the 30 or 50%. Health contingent programs ensure availability of reasonable alternatives and understand different rules for the activity versus the outcome-based rules. And Something you're going to see here at the bottom of this slide, which is going to be different for the next two pieces, is that, again, these rules were not affected by the AARP overrule, but it doesn't necessarily mean that just because you're complying with the ACA or HIPAA that that's going to help you with compliance with the ADA and other laws.
Great, thanks, Dot. So just like with the HIPAA, I'm going to go ahead and talk about the ADA, and just like with the HIPAA rules, one of the first questions you should ask is, well, does my wellness plan even need to comply with the ADA in the first place? And the general or quick answer to that question is that the ADA will apply to your wellness plan if it contains any inquiries or assessments that could be considered or to be disability related, like a health risk assessment, or if it contains any kind of medical examination that is not job related, like a biometric screening that's not being used for the the purpose of the job that's about to be performed. And it's just as a little bit of background on the ADA and wellness. Title I of the ADA has two primary requirements that apply to wellness programs. The first being that the program cannot be discriminatory with respect to disability, which is pretty straightforward, and we're not going to really talk as much about that requirement. The second requirement is that any medical examinations and inquiries generally must be quote unquote voluntary, and voluntary is a term that is not defined in the statute, that contains many different requirements in the regulations that the EEOC issued under the ADA back in 2016, and so it's quite amorphous. And so we're going to talk about that in a little bit, but as you can see from this really the main two requirements that would subject the ADA to your wellness plan is whether or not it contains disability-related inquiries or medical examinations. If it does, then it has to qualify for the terms of this exception, right? So in other words, right, the ADA prohibits you from doing these disability-related inquiries. The ADA prohibits you from doing the medical examinations, but there's this exception, right? The exception applies to voluntary, wellness plans, and the regulations that now, of course, we've seen that the incentive provisions were taken away, but these regulations really defining voluntary are still in effect. A voluntary wellness plan, the term voluntary is defined as it cannot require participation or discipline or terminate based on non-participation. It cannot condition eligibility in or limit coverage in the health plan based on the participation in the wellness plan, and this is referred to as the gatekeeper rule. So in other words, you can't have a rule that keeps someone out of the health plan because they don't participate in the wellness plan. And then, of course, there's no adverse employment action or retaliation that it can occur against someone, and you have to comply with the notice requirements. And there was a sample notice that was issued in June of 2016 that explains it's sort of a model notice that you can use to adapt to your particular organization's wellness plan. And then I think what's important to note here is that for wellness plan to be considered voluntary, there's even more requirements in these. So in other words, these four main requirements are really in the definition of voluntary. But really over the years and for many years, there's been a case law out there that has sort of defined the contours of what it means to be a voluntary plan. And then of course there's the bona fide benefit plan safe harbor, which just basically says that it was a case law created safe harbor in a case in the 11th Circuit that basically said that certain plans that are based on underwriting, classifying, or administering risks that are not a subterfuge for discrimination can do some of these things and kind of get away with it. Now the EEOC stated in their most recent regulations that they don't believe the bona fide benefit plan safe harbor still applies anymore. So probably not a good idea to follow that safe harbor. But it is, we have here an example of the voluntariness requirement in effect, sort of outside of those main requirements, and that's the case of the Orion case, which was the first major settlement between the EEOC and an employer on these voluntary rules. And we're not going to go into all the details here, but basically, the EEOC sued the employer in August of 2014 after the employer required an employee to pay the full cost of the premium under a self-insured medical plan for not completing a wellness plan's biometric testing. The employee complained to management about the plan, the wellness plan, asked questions about the plan's operation, and then was subsequently fired by the employer. EEOC argued that the wellness plan violates the ADA's voluntariness requirement, and then the EEOC settled with the employer in April 2017, and the employer was required to pay $100,000 to the employee and correct the plan, do workplace training, and of course, there's a lot of bad press for that employer. But this is the key takeaways here are that the voluntariness requirement is kind of broad and amorphous. There were other cases. There was a complaint, 2014 EEOC versus Honeywell, where the EEOC took issue with some of the requirements that the spouses had to do. So voluntariness is a broad requirement. So, as a general rule, don't retaliate, Don't fire an employee or retaliate against an employee who complains. And also, you want to make sure that you're aware of some of these cases that are out there in addition to the regulatory rules. So we're not going to go into a lot of the details here about what was invalidated in the AARP decision, but the general rule here is that the incentives, for wellness plans under the ADA is that they could not exceed 30% of the cost of employee-only coverage, with the limits varying based on the interaction of the wellness plan with the group health plan. So as you can see by this big sticker here, the stamp on the top right, these rules have been invalidated, but there were very specific rules for how that 30% incentive limit went into effect. And these slides are really more for your own reference. So we just have them here really more for your own reference. And there was some unofficial EEOC guidance that kind of clarified some of the details and really explain what you're supposed to do. And just some kind of key takeaways here. The ADA rules did make a lot of clarifications that are still in the rule. So when the AARP decision came out and invalidated the incentive provisions, still clarified a lot of other rules about what you can and can't do in your wellness plan. One clarification was that you don't need to have prior written authorization for someone to participate in the wellness plan under the ADA. So you didn't need that under the ADA, but as Dot's going to explain, you do still need that for GINA. Clarified, reaffirmed the EEOC's position against the application of that bona fide benefit plan safe harbor we talked about. They said you can't do that. So there were still rules there. Of course, the notice requirement, there's still things you still have to do that are still in the law. And like Dot mentioned before, compliance with the ADA rules does not guarantee your compliance with the HIPAA ACA rules, so you kind of have to take all the stuff into consideration at the same time. Dot, you want to talk about GINA?
Sure.
Great.
So as background, under Title II of GINA, Genetic Information Non-Discrimination Act, employers are generally prohibited from requesting or soliciting genetic information. And what does genetic information entail? So genetic information means information about the manifestation of a disease or disorder in a family member of an individual, which includes family medical history, spousal medical information, and other genetic information, like, for example, test results from a genetic test. Family members of an individual include someone who is a dependent of the individual through marriage, birth, adoption, or placement for adoption, and any other individual who is a first, second, third, or fourth degree relative, which of course includes an employee's spouses, parents, and children. Okay. However, there is an exception to asking for genetic information, and an employer may ask about family medical history as a part of that voluntary wellness plan that Dan discussed. This is permitted as long as these following rules are followed. Again, that it's part of a wellness plan program providing health or genetic services. Questions asked only about spouse's past or current health condition. There can be no family medical history information or genetic test results, and no health or genetic information about an employee's children. The maximum incentive can, similar to the ADA, cannot exceed 30%. As set forth in the ADA rules, we use the same calculation as the ADA, and unfortunately those wellness incentives were vacated along with the ACA rules. Additional requirements is that the program is reasonably designed to promote health or prevent disease, similar to the HIPAA ACA. The information is provided voluntarily, and as Dan explained, there is not the employee has to do something to be able to even participate in the plan. And the individual providing the information provides a prior knowing, voluntary, and written authorization using a form that describes the type of genetic information that will be obtained, purposes for which it will be used, and restrictions that apply to that information. And additionally, individual identifiable information is provided only to an individual or receiving family member and or the licensed healthcare professional providing services, and that the individually identifiable health information is not accessible to managers, supervisors, or others who make any employment decisions or anyone else in the workplace. Additionally, that the individual identifiable health information is only available for health or genetic services offered by the employer and is not disclosed to the employer except in aggregate terms, or basically de-identified. The employer does not condition participation in program or inducements on agreeing to disclose genetic information, and the employer does not deny health insurance benefits for spouse's refusal to provide information about his or her current or past health information.
Great, thanks, Donna. I'm going to go right into the AARP case. I mean, I think we kind of already talked about the most important components of it, so we don't really need to go through every single fact. But essentially, we're basically left in a state of limbo or in a gray area because of what happened. And just to kind of give a brief overview, right? AARP filed suit against the EEOC in a federal district court in Washington, D.C. Initially, it was attempting to prevent the regulations from going into effect, and then starting to the level of incentives allowed by these ADA and GINA rules was inconsistent with the meaning of the term voluntary. The AARP also claimed that the EEOC failed to explain why it kind of came up with this 30% incentive level and why spouses could participate but children couldn't, and there was just a lot of things that seemed to be arbitrary about the rules. And then in an August of 2017 decision, the judge agreed with the EEOC, but did not invalidate the rules later. In a later decision reached in December of 2017, the judge did vacate or invalidate those incentive rules. And then subsequently, in December of last year, the EEOC issued a regulation that removed just the incentive provisions of the ADA and GINA and kept everything else still in place. So a lot of back and forth there. And just it wasn't always so clear as to where what would happen next, and I think it was really just kind of a really big headache for employers because of all the back and forth. We were telling employers throughout this time to really play it conservatively, but it was just a confusing period of time. So, Dot, do you want to talk a little bit about some of the impact that the case has had on employers' wellness plan design decisions?
Sure, and putting aside all of the legal back and forth, which I know Dan loves, which I like to stay out of, when this first happened, there definitely was a lot of panic. We got a lot of calls. How do we know if we're still in compliance? What should we do? Should we remove the incentives? Should we reduce the incentives? So there are a lot, there's no question about it. We are definitely now, as Dan says, in that regulatory vacuum. In other words, to the extent to which an employer may provide incentives for wellness program participation without jeopardizing its voluntary status really now is uncertain. The vacated provisions of the ADA wellness regulations had provided that an employer could offer limited incentives, whether financial or in-kind, to promote an employee's participation in a wellness program that does include disability-related inquiries or medical examinations. The incentive limitations in these regulations were intended to ensure that participation remained voluntary without the inducement becoming unduly coercive. Now, without that standard, it's just become a lot of more fuzzy as what is coercive and what's not. So in other words, it's not entirely clear where the EEOC will draw the line, and yeah. I don't like that.
Exactly.
I'm in compliance for a reason. I like clear lines. So.
Exactly. Fuzzy is, I think, the perfect word. I mean, there were definitely calls from benefits consultants and ERISA lawyers to plan sponsors out there, in complete, I think that were, trying to get everybody to sort of stop everything, stop what you're doing, right? Get rid of all your wellness incentives right away, bring everything down to zero, right? So there's a little bit of panic there initially, which is probably too conservative of an approach to take, since the HIPAA ACA rules were not invalidated and there's nothing out there saying you couldn't still comply with the EEOC rules. It's just, we're just kind of in a gray area, or really in a vacuum. But among the employers that did respond or that did react to the AARP decision, it was mostly a reaction that involved lessening the incentive and surcharge amounts to a more nominal or insubstantial percentage of the total cost of the premium. which I think were really sort of I guess you could say a most conservative and a less conservative approach. The most conservative approach, of course, is just to take everything down to zero. The less conservative approach was to take it down to a very, very nominal amount. And we've included some examples here that show you kind of what typically happened among the people who did respond to the AARP decision. This first slide shows you a less conservative approach, which was 1%. Each of these items added up to 1% of the employee-only cost of coverage, and that's kind of what you would see most often with those sponsors who did respond. So this is a typical sort of plan design of a wellness plan for an employer that did respond to the AARP decision. And then here you see one, obviously the most conservative approach, just reduce everything to zero, right? And I think one of the big questions, of course, is like, what's next, right? So we talked about the fact that, right, the rest of the rules are still in effect outside those incentive rules. So ADA and GINA still applies. The EEOC has said that they will be releasing their newly proposed issued rules in December of 2019. So we'll be, watching out for that very closely.
Just in time to totally miss your open enrollment for 2020.
Exactly, right? Exactly. So nothing you need to do immediately, right? And we still have to wait and see what's going to happen there. One really interesting thing that did happen was this case of Questle versus Yale University that we briefly mentioned before. It's a new class action complaint filed last month alleging that Yale's employee wellness program was involuntary. It involved several medical examinations, including blood testing, vaccinations, healthcare coaching, and a requirement to disclose health information and medical claims data to the plan. They're saying that it wasn't voluntary because it says in the complaint nearly 5% of large employers impose penalties of $1,000 or more. In this case, the program required employees to pay a fine of up to $1,300 a year in $25 weekly increments. And it further, the complaint notes that New Haven, Connecticut, where Yale is located, is $1,300. $1,300 means nearly 5.5 weeks worth of food, 4 months of utility costs, nearly a month's worth of housing or childcare. But it doesn't actually explain what percentage of the incentive makes it involuntary. So it's an interesting case. Obviously, just a complaint at this point doesn't mean that Yale is, going to be in trouble or anything. But that's kind of where we have to still keep on looking for things. And so really it's sort of a next steps, like what do you need to do in light of everything we've talked about today. The biggest risk out there really is cases like the Yale University case, right? I think it's great to kind of stay the course, stay in compliance with the rules as they exist, make sure there's a buffer between that 30% max incentive limit and what your actually incentive limits are. I think it's, as sort of a big picture takeaway, as you go back to your organization and digest what all this means and all the information we've discussed today, you want to obviously check out your wellness plan designs, and you may want to increase that buffer. But I think it's always a really good idea to make sure that you really understand your organization's culture first before you implement any drastic or dramatic changes to your wellness plan's incentive structure. That is to make sure that whatever incentive structure you're laying out not only complies with the law, but also is appropriate for your workforce and its culture. And then after you've done that, of course, if you don't want to play it completely safe and reduce everything to $0 on the incentives, definitely make sure to create a buffer between that incentive limit and the max limit, or even increase the size of that buffer so that you have more room.
And Dan, when you really think about that 30%, I mean that is can be quite a large amount. So I would say that in most cases, employers really are not approaching that 30 or have the ability of going over that. So, but I agree with you as far as maybe reducing the buffer a little more.
Exactly. I believe it said in the complaint in the Yale case that the average 30% limit was around $1,800, which is a huge amount. Most wellness plans never get to an $1,800 incentive. But I think going back to that first thing I said about it's just so important to take into account the workplace culture, especially because if you make the hurdles too high, that can lead to angry or disgruntled employees, and they may end up suing. And when you look at or try to assess, what are the biggest possible risks or liabilities that are out there and that pertain to your wellness plan, certainly it's not from EEOC audits, because the EEOC really isn't enforcing wellness incentives right now. So really the big risks are the risk of lawsuits that really should be the most concerning for your plan. So in light of that, take the time to think hard and to think carefully before making dramatic changes to your company's wellness plan. And then, relax, breathe deeply, maybe listen to some Oprah podcasts, and go forward with confidence, and get your wellness plan back into compliant shape. So thank you for joining us today, and it was a pleasure.
Thank you so much, everybody.
All right, great info, Dan and Dot. Thank you for that. And everybody on the line, thanks for attending. Please take a moment to complete the brief survey, excuse me, using the teal feedback widget at the bottom of your screen. Your SHRM and HRCI credits can be downloaded now using the yellow certification button. And we'll send the presentation slides and the webinar recording to you by tomorrow. Any further questions can be sent to csg.events@corpsen.com. So thank you for attending today. To stay updated on health and welfare compliance topics, please join our Health and Welfare Compliance Forum on LinkedIn. Enjoy the rest of your week.